Hello everybody. Xin chào mọi người đã đến với buổi Didactic Teaching hàng tháng của Phoenix Medical Academy. Trước khi chúng ta bắt đầu thì mọi người có thể comment trong cái phần chat. Mọi người có nghe mình rõ không? Có thể comment yes nếu mọi người có thể nghe và thấy mình rõ. Nếu tiếp đến nếu mọi người có thể comment vào trong phần chat tên của mình và chuyên khoa của mình ở trong phần chat để chúng ta làm quen với nhau, để chúng ta biết nhau hôm nay là có những bác sĩ nào, những bạn sinh viên nào đến từ chuyên khoa nào. Nếu bạn là sinh viên thì hãy comment là tên cùng là và sinh viên. Thì như thường lệ buổi monthly didactic của chúng ta thì chúng ta sẽ trao đổi bằng tiếng Anh. Đây là một cơ hội để cho mọi người có thể tập làm quen với tiếng Anh ở trong môi trường y tế. Xin cảm ơn tất cả mọi người, bác sĩ Ánh, pediatrician. Hôm nay thì mình xin hân hạnh giới thiệu với mọi người bác sĩ khách mời của chúng ta ngày hôm nay, bác sĩ speaker của chúng ta ngày hôm nay đó là bác sĩ Leon. Bác sĩ Leon Nguyễn hiện là bác sĩ gia đình, bác sĩ chuyên khoa gia đình, đang là bác sĩ nội trú tại bệnh viện Bright Center for GME at Health Point. Bác sĩ Leon Nguyễn cũng là người điều hành và đưa ra ý tưởng là sẽ làm chương trình monthly didactic này cho chúng ta. Vậy thì hôm nay thì bác sĩ Leon Nguyễn sẽ chia sẻ với chúng ta về chủ đề Common Infectious Disease in Primary Care. Nếu như các bạn quan tâm đến chủ đề này thì các bạn và cảm thấy chủ đề này sẽ là một chủ đề hữu ích cho mình thì hãy comment yes. Tiếp đến thì mình sẽ nhường lời lại cho bác sĩ Leon để tự giới thiệu về bản thân một chút xíu trước khi chúng ta bắt đầu.
Hello everyone, my name is Leon. I'm a resident physician. I'm second year now, family medicines. I decided to do this monthly didactic things just because I want to share with everybody what we do in America as physicians and share the most up-to-date practice in medicines, and also share like common things that we see over here, and also give everybody an environment to practice some English. Originally this month's supposed to be some other topics in pediatric, but our pediatrician, Dr. Samantha Gooch, last month, she happened into some kind of like incident that she had to take care of. So I decided to do this topic. It's called Common Infectious Disease in Primary Care. It's technically what you see every day in the primary care clinic. When patients come in, some common complaints. I'll try to make this as interactive as possible. And of course, I'll do like 50% of the speaking, but I'll also will ask you guys to share your knowledge as well. This is not a teaching session. This is just like a share knowledge-based sessions, like where everybody can share their knowledge, whether or not you speak Vietnamese or English. I encourage you trying to do English because this is the only time that you will have the chance to practice. But if you have some difficulty, we can help you out with that. Yeah, that's basically it.
Thank you, Dr. Leon. So let's get started. Now it's 8:06, just to make sure we respect everybody's time. Again, similar to the first session, at the end of today's session, if you stay until the end and fill out our evaluation form, we will send you a certificate of completion for today's session. So back to Dr. Leon.
let me see if I can turn this into a slideshow, which is going to be better. Okay, there we go. Does everybody see like the whole slide? Okay,
Yes.
good. Okay, so let's see. So purpose for this session is just introduce commonly seen infectious disease in primary care setting. We will do some case discussions in multiple choice format. And of course, not all is covered in this section because, you know, there's a tons of them out there, and I just picked the most commonly seen one that I see in the last year to introduce to you guys. So let's jump to case number 1. It should be fairly easy because all I do was just picking like commonly recognized like things for the disease, and then I'll ask everybody to tell me like what do they think it is and then why it's not the other one. Okay, so can somebody read this to me? This is a good chance to practice some reading right here. So anybody can volunteer. It's okay.
The answer is D, EBV.
Well, let's read the question first. That's a little bit fast, but let's read the question first. Okay, let's read the question. Since you already speak up, Dr. Anh, can you read the question for me?
I don't hear clearly.
Can you read the question for me? Like read the whole thing, like starting in the beginning.
Okay, I read the question again. The 12-year-old man comes into your clinic with a sheep complaint of sore throat that started about 3 days ago. His parents report that he also have high fever, 102.5 degree Fahrenheit, or 39.1 degrees Celsius, and some swelling of his neck. Physical exam reveals phalangeal edema, patchy tonsillar. I don't know the word. Exudate and prominent tender and anterior cervical. It's very difficult to pronounce.
Oh, that's fine.
Diagnosis. I think the answer is
Này hay đấy.
Did somebody just say something? So a very good job in reading the whole thing. Just to point out, this one's called pharyngeal edema. That's how you say that word. Okay, pharyngeal edema. The other one is patchy tonsillar exudates. Okay, and the other one is prominent tender and anterior cervical lymphadenopathy. So if I don't mention anything in my physical exam, the other exam are normal, like lungs, heart and lung exam are normal. Okay, so what do you think it is? I saw that everybody kind of picked D, EBV. Yeah, that sounds like a very good answer. So let's discuss. Why do you guys think it's EBV?
Because I have experienced some cases have a clinical situation like that. EBV have a phalangeal edema and white, and I think it's a white patchy tonsillar. It's red, so I guess it's is EBV.
That is good reasonings. That I agree. But I think the answer may be something else, not EBV. If you look at the tonsil, yeah, there's some patchy exudate, but there's also like some petechiae right here, and the fever is very high compared to EBV. With EBV, the fever usually milder, And patients usually 30% of the patients, according to UpToDate, have splenomegaly, which is the enlarge of the spleen. However, I agree that it is very hard to tell between EBV and bacterial pharyngitis. Definitely not influenza, because you know how influenza presents. They usually don't have tonsil exudates. We all know what COVID looked like. We all experienced COVID in the past 2 years. So, and definitely not HIV, because it seemed like patient doesn't really have a lot of risk factor. I don't give a history of any immunocompromised conditions. So the answer is actually B. Between B and D is really hard to tell. That's why I prepared the next slide, which is going to help you distinguish what's the EBV. It's actually, but so let's discuss about the treatment first. So we think this is bacterial, but we don't know what bacteria it is. So, well, okay, I already reviewed the answers. That's not a really good thing. But the answer is we usually treat this bacteria with like oral amoxicillin 500 twice a day for 10 days. Or you can do it 1 gram once daily for 10 days, which is totally fine. In patient with penicillin allergy, we do cephalexin 500 for 10 days, twice a day. And if it's resistant group A streps, we do clindamycin. Of course, we treat in presumptive of group A streps. We don't usually swab for this, but we can. Usually we treat it in presumptive that the cause is a group A strep, but there's other thing can cause group A strep as well. Usually either like I will give the antibiotic if the patient looks sick. If the patient doesn't look really sick, like it's most likely probably not bacterial. So it's dependent on the clinical picture as well. Usually I give the antibiotics anyway, just because I don't want to miss group A strep. If the patient fever was really high, that's the indication. There's something called Centaur Criteria. Does anybody hear about it? Does anybody know Centaur Criteria? I can type it up here. Does anybody know about this? Usually this is the scoring system I use to determine if the most likely cause is the group A strep pharyngitis. And usually they have fever, that's 1 point. Tonsil exudates, that's 1 point. Patient doesn't have a cough, that's another point. And anterior cervical lymphadenopathy, that's another point. If the patient is also between age 3 to 14, that's 1 more point. So which is outpatient, which is like 14 years old. So patient got 5 points on Centaur Criteria, which is definitely we should treat it with antibiotics. Okay, so if nobody knows Centaur Criteria, or if you heard about it, you can look it up. It's a very easy thing, accessible. Yeah, usually I treat it, and then patient usually improve 24 to 72 hours, and then we follow up in 1 week for monitoring. So this is the bonus question. If you do not treat this, what complication can arise from group A strep pharyngitis? Anybody know what happened if you don't treat this? Rheumatic fever. That's right. That's a very typical board question right there. It's rheumatic fever. What else? There's something else. Something related to the kidney. something related to the kidney, because if you don't treat this, you have something related to the kidney. It's called Cormagelein Nephritis, which very interesting. I never seen this though. Usually a patient in America, they usually got treated, and so I haven't seen the case of group A strep Cormagelein Nephritis in a while. I see other kind of Cormagelein Nephritis, but I haven't seen group A strep Cormagelein Nephritis. It's really rare. Okay, so we were confused between EBV and bacterial pharyngitis. So for EBV, the lymph node is usually posterior. So you will see posterior cervical lymph nodes and auricular node, which is behind the ear, usually. The anterior node, usually the bacterial one. Okay, fever of EBV usually milder. Patient will not look that sick to you. You should use your clinical picture. Patient usually have a really milder fever than bacterial. And usually the onset is slower than the bacterial pharyngitis. Bacteria is acute onset. It's usually really fast because it's bacteria. Viral one like EBV is usually will take a couple of days. Sometimes I saw a case of EBV like 1 week, like onset, which is very, very mild. Definitely there presents a palatal petechia, which is some like you see the blood vessel on the palatine area of the mouth, and definitely posterior cervical adenopathy. They are highly suggestive of this disease. The absence of cervical lymphadenopathy and fatigue usually make this diagnosis less likely. Of course, we do recommend that to young adults who have EBV to avoid playing sport for 4 weeks at least. You know why? You know why we tell people with EBV to not doing anything hard in 4 weeks?
Dr. Leon, yeah, I think because they have a enlarged spleen, so they have to avoid strenuous exercise.
That's right. Because they are at risk for splenic rupture. So if they rupture their spleen and die, that's a really bad thing. We don't want that. So I usually tell the kid, do not play sport for 4 weeks. Okay. So yeah, that's a very good case to tell the difference between EBV and pharyngitis. Of course, clinical presentation matters. So I just want to share this, and hopefully everybody have a better idea of how to tell a difference. It's okay. Sometimes I still make a mistake of like telling them apart, but it takes practice. So let's do case 2. Somebody reading case 2 for me, please. Volunteer.
I will bring case 2.
Perfect.
A 5-year-old female coming with chief complaint of course that started 3 days ago. She also noticed some hoarseness of her voice. She described noises that she noticed at night. Denies denies any difficulty reading or swallowing. Physical exam does not reveal any wheezing or airway obstruction. X-ray reveals following images. What is the most likely diagnosis?
Okay, so as I mentioned before, whatever I don't mention is usually normal. So the patient vital signs is normal. Physical exam, pretty much normal. No wheezing, no lobar consolidation signs. Heart exams, normal, everything is normal. Okay, it's just some weird high-pitched noises that she make at night. So before we jump to the answer, I know everybody know the answer because this is very typical. This is like classic textbook presentation of this disease. Let's rule out each of these first. Let's see why is not root-based strep. Well, that's why is not A is the answer. Because I don't give you the toss from the X-ray picture. Well, A is definitely not the answer because the patient doesn't really have fever. Because I say vital signs normal. Patient doesn't really have sore throat or complaint, so it's very low on the list. COVID-19, well, we all know how COVID presents to this point. You will have like cough, shortness of breath. The X-ray will look a little bit worse than this. And definitely still on the list, but we're just gonna keep it there for now. So I am between B, C, and E now, and somebody can pick out the answer for me between three of these and tell me why you think it is. I may have to pick on someone. Didn't we say we have a radiologist here? I saw earlier somebody introduced a radiologist. Maybe they can tell me about an X-ray. I think Dr. Chi is a radiologist. Why do you think the answer is B? Tell me about it.
It's the Laryngo Tracheitis because it has backing noises, and if the answer is B, epiglottitis, the patient has difficult breathing or hard in swallowing, and so the answer is C, Laryngo Tracheitis.
That's good. Okay. Why is not RSV though? C is the correct answer. The reason why is not B. Well, I'm not saying it's not B. I'm just saying it's unlikely to be B. Is because this patient presentation is kind of normal and not that sick. Again, we have to look at the patient presentation. Patient does not have any difficulty breathing or swallowing. Of course, with epiglottitis, patient will have difficulty swallowing, and usually they drooling as well, and they will sit in the very weird tripod positions to help them breathe. And that's an emergency. We need to send them to the emergency room so they can get the airway management, because we don't really taking care of that in the outpatient clinic unless we have the tools to. At my clinic we don't. I don't know if Dr. Christina Nguyen have the tools at her clinic to do that, but definitely at Health Point we don't have that. RSV usually have wheezing, and the X-ray look a little bit worse than this. Maybe Dr. Chi can tell me a little bit of X-ray. What do you see with epiglottitis on the X-ray? And what did you see with laryngo tracheitis?
On this X-ray, the first I see the one lesion in the basal region of the left limb, and I think that is the image of pneumonia, and moreover where you can see in the region of the trachea, in the upper part of the trachea, you can see the image like a top of a epidemic, the angle planet. Yeah, this is a typical image of epiglottitis and HIMAC. So in conclusion, on this X-ray, I see two things. The first is the lesion of the epiglottitis, and the second is pneumonia of the basal left lung, and that's on for me. Yeah.
That's very good readings. Yeah, you mentioned about the pyramid sign. I mean, that's the sign for Laryngo Tracheitis. I think that's what you mean. It's called the steeple sign. That's what they call on the board exam. It's called the steeple sign.
That is a name.
Yeah, that's called the steeple sign. Yeah. Yeah, there's definitely, now that you mentioned it, I saw some infiltration, but like, be mindful that laryngo tracheitis can become laryngo tracheobronchiolitis, which is they become infection of the lower lungs, which can cause some of the X-ray finding. On the lateral X-ray, you definitely can see it, like the really sharp, like pointing of the pyramid on this side over here. Usually with epiglottitis, you saw something called thumbprint sign, which is like a thumb, and you put it on the X-ray and you see it. I don't see it over here. So definitely not looking like epiglottitis. Yeah, so thank you. That's a very good discussion with everybody about this one. These are very easy to confuse. That's why I picked those, because I can talk about 3 or 4 diseases at one question. So there's something called a Wesley score for laryngo tracheitis. The old name is CRUP. This is just for your reference. I don't really use this, but we use this to like assess the severity. Usually with like children, like infants, less than 12 months. Usually my attending usually tell me to assess severity, how severe it is. Does the patient need to go to the ED to manage? Because you know babies can get sick easily and they get sick fast. So this is just for your reference. It doesn't have to be memorized or anything, but it's just know that we have some tools to even tell that CRUP can be severe or not, which is laryngo tracheitis. So talk about RSV. Typically feature for RSV usually younger patients, usually infants, less than 12 months old. Patients usually present with wheezing, difficulty feeding, and respiratory distress. CRUP doesn't really have respiratory distress unless it's severe. At that point, we need more workup to determine the etiology. Because treatment for CRUP and treatment for RSV is totally different. So the X-ray of RSV usually demonstrates these like patchy atelectasis that you can see, especially in the right middle lobe as well. Like right here, you can see some patchy infiltrations. They're bilateral peribronchial infiltration. Especially the lung look more black, which indicate like hyperinflations. There's a lot of air, which means that there's some obstruction going on. Patient can get air out. And usually in severe cases that we see this. And you can definitely see on the lateral X-ray, you can definitely see the patchy atelectasis. Maybe they have some underlying pneumonia as well. We don't know. We have to determine that using clinical features. So that's RSV for you. COVID, I want to talk quickly about COVID because we all know COVID up to this point. To determine COVID nowadays, we have a rapid antigen test that can be done quickly. I actually have one down here in my room. because we give it to everybody to go home and keep it there in case you feel sick. But yeah, rapid antigen test nowadays is readily accessible. People can quickly test for it, so you can rule out that answer right away. Is a patient got COVID or not? Just do the quick COVID swab test and you know right away. We have to evaluate if the patient have COVID. We have to evaluate how severe this COVID is. And we have to know how long that the patient has COVID already, because it's important in terms of treatments. So to evaluate for severe disease, patient vital signs is important. You have to make sure that patient is not in sepsis, so which is like high pulse, like high respiratory rate. SpO2 is less than 90%. Patient is in severe dyspnea, which is difficulty breathing, really bad, at rest, and they still have like difficulty breathing. That's a sign of severe disease. Or if they can speak in complete sentences, at room air, and all their mental status is not normal. You can easily assess their mental status by asking about their orientation, like do they know where they are, do you know what the date is, blah blah blah, what the time is, who's the president, stuff like that. Okay, and that is an indication for severe disease, and they need to go to the emergency room right away. They can't be managed in the clinic because they're unstable. So the treatment outpatients have been updated recently. We have something called Paxlovid, and that's a brand name. It's a combination of nirmatrelvir and ritonavir. I can't say those. And monoclonal antibodies. This is so hard to say. But yeah, it's a combination. It's usually nirmatrelvir 300 milligram with ritonavir 100 milligram. I don't know if Vietnam have those yet. But over here we have those in the clinic just to be ready. We usually only preserve those for like severe patients. Or because like this even though we have it, it's very like not a lot. We don't have a lot of them, so we usually save them for like, okay, does a patient looks like they need to be treated or not? So this is already based on your clinical suspicion. Do you think the patient need to be treated, or you think the patient symptom will go away in a few days? And things to determine that is the patient vaccination status. Is the patient vaccinated for COVID? Is the patient being vaccinated for COVID? If not, then usually I treat it because they're at risk for like severe disease. If they kind of like having a high fevers or like they look a little bit sicker, then I usually treat it. Usually we have to give this within 5 days after COVID-19 diagnosis, because after 5 days, the efficacy isn't really that high. They just show that there's decreased efficacy of this medication after 5 days. If the Paxlovid is not available, then we can also go to remdesivir, which is we use it all the time in the hospital. So they have to go to the hospital to get IV remdesivir. And then if either dose is not available or not appropriate, then betalovimab is an option. And this is hospital stuff, so they have to go to the hospital and get this. However, usually I just told my patient, if they don't look that sick, I just told them to go home, do supportive care, take acetaminophen for fever, drink a lot of water, stay hydrated, and isolate yourself for at least 5 to 10 days or until your fever is gone without fever medications. That's usually what I tell them. I usually just give Paxlovid to like a severe patients or patient that think that they need to be treated. I don't know what you think, Dr. Christina Nguyen. Do you treat the patient with COVID in the clinic?
Yeah,
this is very new.
I think we have similar guideline. We usually reserve it for severe cases.
Yeah, because HealthPoint, at HealthPoint, the guideline is we don't give them out to like mild COVID disease. One thing that I found interesting on my reading is betalovimab doesn't really have that much efficacy to the Omicron variant, the Omicron 2 variant. But that's just some side note. Nothing really important because we all know how to treat COVID nowadays, right? So this is another like table for FYI. This is just for your information, just reference. That doesn't really need to be memorized. Everybody should have access to the slide after this, so you can all look at this when you have time. So yeah, so we determine the patient have group. Again, I give out the answer. What do you plan to give to these patients? Just for the context of time, I'm just gonna say that for my group, there's some evidence show that in children, we usually give 1 dose of oral dexamethasone steroids. And we measure it based on the 0.15 to 0.6 milligram per kilogram. Maximum dose is 16. Or we can just give oral prednisolone 1 milligram over kilogram. And this will show to shorten duration of symptoms. It doesn't really cure the disease. The disease will go away mostly on its own. So that's why in adult, it's like supportive care. And usually I will leave this to your discretion if you want to give children steroids or not. Usually I don't, but this is just something that I find out when I do my reading on UpToDate. And yeah, they do recommend that. I usually do not, but we don't usually base on guidelines. We have to base on our clinical judgment as well. And again, if patient is severe, you send them to the emergency room, okay? Because we can't manage the airway in the clinic. We don't have intubations maneuver in the clinic. Okay, so that is for case 2. Let's go to case 3. A little bit more information this time. And case 3 will be a little bit longer discussion. That's why I don't have a multiple choice. So for the context of time, I'll read this for you guys. So I have a 45-year-old male coming with the chief complaints of cough and fever. That started about 2 days ago. He also admits that he got some shortness of breath. He also has some productive cough with green sputum. History, he's a smoker with 1 pack a day for 20 years. So that's like 20 pack years of smoking. He have no history of diabetes, COPD, or asthma. No hypertension either. So patient vital signs, blood pressure is 140/90, respiratory rate 26, pulse is 100, SpO2 is 93%, his temperature is 102.5 Fahrenheit or 39.1 Celsius. Physical exams reveal crackles, and there's some dullness to percussion in the right lower lobe. The rest of the physical exam is benign, which is heart, lungs, abdomen exam are benign. So what's your differential diagnosis? You can all type in the chat or you can say it. I want to know what's your differential for this one. Differential diagnosis. What do you think it is?
Yeah, may I can answer?
Yes, tell me the differential that you think it is.
For this patient, I think there are some diagnoses should be mentioned. The first, either acute pneumonia.
Okay, that's good.
Or maybe it's more severe in an abscess of the lung. Because the patient with a high fever and he had a green sputum, something like that. And moreover, on the basis of the patient that he had a shortage of breath and also had a history of smoking. So that on the length of COPD is maybe mentioned. I mean that the patient can have a risk of like tuberculosis. Yes, tuberculosis. I mean, it's the second diagnosis that I want to say, that acute stage of tuberculosis.
Okay, sounds great.
Yeah, and
tuberculosis.
That's two main diagnoses that I think first of all. Thank you.
Okay, let me ask you guys something. Oh, I saw in the chat, patient have acute respiratory distress. That is very correct. What is something that you cannot miss that may kill this patient? Let's put pneumonia aside. Something that you absolutely cannot miss that may kill this patient should be on your differential first. Something that can kill. Well, COVID. Yeah, COVID can definitely kill everybody. Yeah, definitely COVID-19. I agree. We can't miss that. Something else that I'm looking for that may kill this patient. Usually when I see that decreased SpO2, elevate respiratory rate, pulses is elevated, I'm kind of worried for this. I mean, I don't worry about fever right now. I'm worried something else. Start with a P. I mean, pneumonia also start with a P, but this is more serious that I want to make sure. O2 supplements, elevate head position. That's a good plan. I agree, definitely. Okay, something that I don't want to miss is the pulmonary embolism. Pulmonary embolism that may kill the patient. So that should definitely on your differential. So our differential will have pneumonia, COVID, pulmonary embolism, pneumothorax, spontaneous pneumothorax can cause this. You never know. Who knows? Like they have fevers. Just something that make sure that we don't miss. Also, pleural effusions, heart failure can may cause very similar thing. What else that may cause very similar things? Sometimes like obstruction, like if you swallow something and then obstructed in your lung, that can also causing some respiratory distress. So yeah, good job everybody doing some thinking out of it. So differential diagnosis include but not limited to pneumonia, bronchitis, COVID-19, influenza, URI, upper respiratory infections, heart failure, and pulmonary embolisms. Okay, so what do you plan to do? What do you guys plan to do for this patient? I saw O2 supplement and elevate head position, which I really like. That's something that may make your patient comfortable. Yes.
I'm not a clinical, I'm not a clinician, but in my viewpoint of a radiologist, the first thing I will do is infectious billing for the blood test and everything that will confirm the infection. And the second is very important is a stress CT scan with contract to confirm that where if there is a lesion in a lung, and as you say that to to exclude an embolism on this body, because it's very important. Yeah, and that's all my question. Thank you.
That's very good, but remember that I work in the clinic and I don't have a CT scan. I don't have a CT machine in my clinic. But yeah, chest CT with contrast. If this is an emergency room, I'll definitely send this patient for CTA just to make sure that he doesn't have a PE. Plus also the CTA will tell me if they have COVID or pneumonia, which is a perfect image And also CBC, definitely I agree. D-dimer, great. D-dimer is a great choice. We are all emergency doctor here. Yeah, we get D-dimer. I agree. Yeah, but this is a clinic. So the only thing I can get in the clinic is sent out for labs and waiting. With your clinical suspicions, we don't have the CT available in the clinic, so all I can do is get an X-ray for the moment. And then if I really worry, I'll send my patient to the emergency room to get the CTA. But that's not the case. So I agree with all your plans. All your plans sound great. We are in different settings. We can do different things, but I agree. We should rule out the most dangerous cause. That's why this question have multiple answers, and nobody answer is really absolutely correct. Everybody is correct at this point. We are going to do everything to save the patients, and everybody does the right things. Yep. So I do the COVID swab, and the COVID is negative. So let's say that I don't have the X-ray and I live in a very rural area. I'm just going to treat this like pneumonia at this time, because given the patient clinical pictures, again, it does look sick. So I definitely recommend the patient to go to the ED. However, let's say that we don't have the CT scan and we don't have the chest X-ray available, and all we have is just this patient and us in a very rural setting, which is a blood test. I'm just going to treat this like pneumonia and tell the patient to notice me, call me back if they develop any respiratory distress, like really severe. Because from the clinical picture, pneumonia does sound like a very likely at this time. For patients with pulmonary embolus and heart failure, usually you recognize them right away because they look very sick. This patient doesn't really look that sick yet, but it should still be really high on your differential. So usually let's say that the patient have pneumonia. What do we treat for pneumonia? How do we treat pneumonia? Everybody knows how to treat pneumonia, right? So there's a few things we consider to treat for pneumonia, especially antibiotics. We need to target a couple organisms, which is strep pneumo is the most common one. Haemophilus influenza is the next common one. And we need to cover atypical like Mycoplasma, Legionella, Chlamydia. Dr. G mentioned a very good bacteria called tuberculosis. In America, we don't have tuberculosis, but definitely in Vietnam, we do. I know that you guys have a specialized hospital for that. In America, we don't have tuberculosis because if patient have TB, they get sent to the public health and they'll take care of that. But yeah, they don't have tuberculosis in America. So let's just say that patient doesn't have tuberculosis for the sake of the discussions. For older patient, we want to extend coverage a little bit to cover some gram-negative pathogens like beta-lactamase, influenza, varicella, and MSSA, aureus. People with structural lung disease, usually we need to cover for Enterobacter as well, like E. coli and Klebsiella, because they are also very common. So yeah, for the sake of this discussion, since we talk about infectious disease, let's just say patient have pneumonia. But again, the discussion earlier we had was really good. I agree with all of your plans. And good thing that we all think about dangerous thing that can kill the patients. So this is just another table for FYI, just for summary of like how to go through the steps to choose the antibiotics. Usually I just pick amoxicillin clavulanic. This is the one that I use the most in the clinic. And I added on with azithromycin to cover atypical, just to make sure that I got the extend coverage. Sometimes just amoxicillin is fine, but usually nowadays we have atypical running around. We don't want to miss that. So case number 4. So now from case 4 forward, it's going to be really fast discussion. For some reason, the picture's covering my... So I'll have to adjust this a little bit. One moment. How do I asset to this? Oops. There we go. Let me move the picture up here. Okay. So yeah, let's read the case. Somebody want to read the case? Do you guys want me to read it again?
I can read the case if no one volunteers.
Okay, well, thank you.
Oh, yeah, somebody volunteer. Go ahead.
Oh, okay.
I read the case. Yes. 30-year-old male comes into clinic for chief complaint of non-bloody diarrhea. It started about 2 days ago. He reported that 2 weeks ago he went camping with his friends in a mountain. He reported that he drank stream water during that trip. Multiple friends served his also suffered from the same condition recently. He noticed that his stool is very foul smelling. He also reports some abdominal pain with nausea and vomiting as well. Denies any association with any type of foods. Deny any fever, chest pain, SOP. Vital signs are stable. Physical examination findings are only significant for generalized abdominal tenderness with no report and negative Murphy sign. Stool sample was sent revealing the following findings. What is the most likely pathogen that causes these patient's symptoms?
Oops, I didn't know that I muted myself. Good job. That's a very good reading. You got most of it correct. So what do you guys think? Well, I already have some hint down here, but this picture will tell you perfectly what it is.
I think this Ikateria coli, maybe because the patient's symptoms.
Okay. Yeah, patient have non-bloody diarrhea. And he went camping 2 weeks ago. Probably drink some bad water over there, because stream water is unfiltered. Yeah, so the answer is C, is Giardia. This is Giardiasis. I can't say that word, Giardiasis. Yeah, it's very hard to say that word as well. So why is not Campylobacter and Salmonella? Because they usually present with bloody diarrhea. This is non-bloody diarrhea, so it's unlikely bacterial. Diatemomoeba fragilis usually present with elevated eosinophil. I'll give you that if they have that, but apparently they don't, and this is very rare. You don't really get infected with amoeba that often. Only people in Florida usually get a higher chance of getting amoeba. Well, that's just a fun fact, but you don't really get amoeba that often. So I'm between C and D, which is E. coli, which can cause travel or diarrhea. But usually E. coli is a bacteria, and usually they cause a more acute onset. So like usually if he drink that water, he will see that symptom like about a day or two after, not just like 2 weeks later you start to develop some symptoms. So this is more likely Giardia, plus the picture tell we perfectly this is Giardia. Even if we don't have a picture, we should be able to tell this is Giardia. Because of foul smelling stool with non-bloody diarrhea usually just point me toward that. So yeah, very good discussion. Giardia. See, the next slide is case 5. Anybody know the treatment for Giardia? Just extra information, not like we do anything too much for this. Usually the treatment is tinidazole, 1 dose, 2 grams, and that's it. So case number 5, 75 years old female. Oh, well, the pictures again. For the context of time, I'll do the reading, and then I'll just ask what everybody thinks. I just saw this like 3 days ago when I work in the emergency room. But yeah, 75 years old female coming with chief complaint of rash. She reports that the rash started about 1 day ago on her back and it's very painful. She denies any radiation of the pain. She rated the pain at 8 out of 10. She's currently taking metformin, gabapentin, lisinopril, and prednisone. Recently, patient was treated for the urinary tract infections with antibiotics in the emergency room about 1 week ago. Past medical history include type 2 diabetes, hypertension, and Crohn's disease. Patient vital sign is stable. Patient is not up to date on all her vaccinations since he was 5. Physical exam, review the findings below, which is this one. What's your diagnosis? Oops. So what do you guys think of this? This is a very, very textbook rash. The answer is C, correct. Is shingles. Yeah, this is actually shingles because it's very typical. And it's usually only on one side, unilateral, and it's follow the dermatome level. I think this is about like C4, C5 level. Could be C6 involved as well. Yeah, so this is shingles. Yeah, very painful rash, shingles in the elderly female. Usually what triggered this can be what I thought when I talked to the patient. This is the real patient. When I talked to the patient was could be the UTI, and she's taking antibiotics and prednisone, which also will lower her immune system. Sometimes that can cause the shingle flare to go up. So this is shingles. Yay, we got this. So treatment for shingles, let me go a little bit quicker in the context of time. The first line is valacyclovir, 1,000 milligrams 3 times daily for 7 days. Could be vanciclovir as well, and acyclovir can be used. I usually avoid acyclovir just because it has some kidney issues. Usually I use valacyclovir because of the least side effect profile that it has. And I give the patient something for pain as well. Usually you can easily control the pain. The patient's already taking gabapentin. So I don't want to do anything for this patient in the ED by giving more medications, especially in the 75 years old female. If I give more medication, they will increase the risk of some side effects. So usually I give the patient topical capsaicin cream. This is very effective for neuropathic pain, and they just put it on their body 4 times a day. But this is just some pain regimen that you can take a look. And this is all up-to-date information as well. So do we still have time? It's 7:02. It's 9:02, so we can quickly go over this case number 6. Again, I'll read the case in the context of time. Sorry, 23 years old female come to the clinic, chief complaint of painful urinations. She said that this started about 2 days ago. She also has some mild fever, urinary frequency, and hematuria. She denies any abdominal pain, flank pain, nausea, vomitings. Her vital signs and physical exam findings are unremarkable. A urine pregnancy test is negative. A urine dipstick in the clinic that we did review 2+ leukocyte esterate. This is shortcut for leukocyte esterate, and positive for nitrites. What's your best next step in management? Are you going to treat this patient with empiric antibiotics and then send the urine for culture, or you just reassure and say, hey, this is going to be okay, come home and come back like later if you have symptoms, or we just send for culture and wait for susceptibility and 2 treatments? And I saw that Dr. HhenNG is saying that the answer is A. What's everybody think? Yeah, it's definitely patient is symptomatic, right? We definitely should treat this and not let the patient go without treatment. I mean, if the patient is asymptomatic, then I will think about like, hey, I'm going to hold back a little bit on the treatment. Or if the patient is pregnant and asymptomatic, then yeah, I treat. But yeah, I will treat this with empiric antibiotics and then send the urine for culture. That's the most appropriate standard of care that you should do. So a couple of differential diagnosis for UTI. It's kind of a lot of information, but for people with urinary tract infections, we have to consider why they have a UTI. They can just like suddenly have UTI. Well, sometimes UTI can be from spontaneous causes if you like not taking care of yourself too much, like homelessness. People usually get UTI. So a couple of things is vaginitis. So in the woman with dysuria, if they have vaginal discharge, usually that can signify vaginitis. And we should consider yeast, trichomonas, or bacterial vaginosis at this time. If the patient have urethritis, if they're sexually active, and the urine usually doesn't show any bacteria, we can consider chlamydia, gonorrhea, trichomonas, candida, herpes simplex virus. But I didn't ask the patient about their sexual history anyways. So that was a little bit bad on my bad, but if I don't mention it again, it's usually they're not sexually active. Let's just say that. The one thing that's very dangerous not to miss is the PID, pelvic inflammatory disease. Usually they will present with pelvic pain. This patient doesn't really have pelvic pain. And fever as well. Fever is usually really high as well. Yeah, so this is something that just checking on the patient. Usually OB-GYN doctor will also examine the vaginal canal to make sure that the patient doesn't have PID. But I don't do that. I just based on the clinical symptoms and based on clinical presentation. Something that we can really do in the clinic quickly is the wet mouth. And usually that can tell us right away if the patient has symptom of vaginitis. And if we do the wet mouth, we see these things. So this is a very fun thing to see under the microscope. You see clue cells in bacterial vaginosis. You see some high multi-trichomonas. with some like motility that can move around really quickly. And also you see budding yeast with candida if they have candida. Okay, so let's talk about treatment. So what do you treat patient with UTI? Of course, we treat with antibiotics, right? But anybody know what antibiotics will you treat people with UTI? You can type it out. You don't have to say it. And if you're shy, who's a OB-GYN doctor here? I saw somebody introduce themselves as OB-GYN doctor. Yeah, I know it's antibiotics. I just want to know like what's specific. Oh yeah, augmentin. Augmentin is good choice. There's a Dr. Trent here. Is he still here? Or he or she? Trent. Oh yeah, we treat them with antibiotics, and usually first line treatment is nitrofurantoin. If this is uncomplicated UTI, it's 500 milligram BID for 5 days. Usually if patient is pregnant, we avoid it in the first trimester. Yeah, augmentin is good. Bactrim is oral BID for 3 days as well. Fosfomycin 3 grams. I rarely see this being used, but this is just up to date. Augmentin definitely good. I like using augmentin, which is amoxicillin clavulanate, 500 milligrams BID for 5 to 7 days. And also you can consider cephalexin, which is Keflex, 250 to 500 every 6 hours. So there's a lot of choices, and each clinician is different in their choices. And some people like augmentin better than the other. Usually I need some empiric coverage to make sure that it's covered my culture. Usually I just send augmentin or Bactrim to be sure that the culture come back and the bacteria is not resistant to the one that I choose. Good job, everybody. Similar, we go to all the sick cases, which is very common infectious disease in the clinic. There was a little bit of discussions during pneumonia cases, and we have a really good time discussion there. So thank you everybody for participate, and I'm taking question now. Of course, these are the resources that I use. Shortcut. I can click all the article that I use. Questions? You can always email me too as well if you're shy to ask the question, but any question on vocabulary, or you want to say certain words in this lecture that you don't know how to say? Okay, it seems like nobody has an urgent question, so I'll let Dr. Christina Nguyen taking over.
Thank you everybody for joining our monthly didactic section today. I hope that you had some useful information, some review. If you feel like the session was helpful for you, please comment yes in the chat box for us. Please let me know if there are certain topics that you want to learn about. A future session, we have a plan for the rest of the year, but we love to hear your input as well. Thank you.
Yeah, just a sneak peek on the plan. We do have a plan for some the next month. I do have I'm still waiting for confirmations, but sneak peek is we're gonna talk some psychology next month. So
this will be a very interesting talk because mental health is so important. For the last part, if you would please fill out the evaluation form for us so that we can learn to improve our future session for you. Also, if you complete the form, we will also send you the certificate of completion for today. And if you can turn on your camera so that we can take a photo together, that would be wonderful to keep the memory of our session together.
Be great. Everybody turn on the camera, please.
As a sign of respect for our speaker today, Dr. Leon.
Thank you, everybody. Please definitely fill out evaluations, evaluate me, send me questions. Definitely, I want to do better next time as well and continue to improve the quality of the talks that we have in this project. So appreciate everybody's time.
Yes. Thank you everybody for joining. So let's see if we have everybody on the camera. I see a lot of people on the camera. Dr. Chi, Dr. Thu, Dr. Hương, Dr. Hương Phạm, Dr. Phi, Dr. Phương, Dr. Zheng, I think medical students, maybe. Cao Khóa, yes. Thank you, Dr. Anh. Okay, so let's take a photo together on 3.
Everybody, if you can turn on camera, or if you have camera, please turn on. I want to see everybody's faces.
Yes.
It's nice.
Yes.
All right.
Okay. Thank you so much, and wish everybody a wonderful night in Vietnam, and Dr. Leon a wonderful day in the US.
Thank you. Thank you.
Yeah. Also, today is Father's Day in the US, so we would like to extend that wish to everybody's here who is a father. Maybe Dr. Phi is a father. So have a good night, everybody. Have a good day, and we'll see you next time.
Bye. Happy Father's Day.